we have to know that it is must be good correlation between the hypothalamus, hypophyse, and the ovary. And not only this, there is the whole number of different inhibiting and stimulating hormones who are included in this system. And also it is very important to have intact normal endometrium, which will be possible to respond on the hormonal influence, and also anatomically normal genital tract for passing the menstrual blood. So if it is disturbance of any of this level, we will have, of course, disturbance of menstrual cycle. So first of all, we have to speak about the hypothalamus. And the hypothalamus is secreting its hormones, which are called hypophysiotropic hormones, or releasing factors. And they are coming through portal circulation to the hypophyse to inducted secretion of hypophyse hormones, which are gonadotropins, and then gonadotropins have influence to the ovary to secrete its steroids. These things which you know, we will just repeat. So first of all, to speak about the hormones of hypothalamus. Releasing factors or hypophysiotropic hormones of hypothalamus are polypeptides. It means these are hormones which have low molecular weight and very simple chemical structure. So it was possible to synthesize them as early as it was in 1971 by Shelley and co-workers, and later on they were also used for test of function of the hypophyse, like Kester, Kaller, and so on. You can find some names. Also, they were later used for induction the ovulation. There are three hypophysiotropic or releasing hormones. This is releasing hormone for FSH, for follicular stimulating hormone. It is releasing factor for LH, and inhibiting releasing factor for LH. These hormones in hypothalamus are secreted in three centers. One is nucleus arcuatus and nucleus ventromedialis, where these hormones are secreting basically. And another is nucleus supraopticus, where the hormones are secreted cyclically. In the man and in the woman, the both centers at the beginning exist, but in early fetal life, by fetus testis, this cyclic center was inactivated in early embryonic period, so this cyclic center in men didn't function. This is the reason that the gonadotropins in the men are only basically secreted, but if some noxa is disturbing this cyclic center in the women later on in the life, so then we will have polycystic ovaries. So this is about these hormones of the hypothalamus. We said that they are through portal system arriving to the hypophyse and then help to secreting its own hormones, which are gonadotropins. So we know three gonadotropins hormones. This is FSH, the hormone of hypophyse, who is necessary to growing ovarian follicle. And then LH, hormone which is necessary to complete maturity of the follicle for ovulation and for corpus luteum formation. And LTH hormone which is necessary for lactation in the woman. The hormones of hypophyse are proteohormones. It means they have high molecular weight and very complicated chemical structure. So it was not possible till today to synthesize them, but it was possible to isolate them first from the brain of the sheep as early as it was in 1958 by Genzer and co-workers. And later on in 1961 they were also extracted from the brain, from the human brain, and you know the great name in the field of infertility, Professor Unefeld from Israel. he actually first used it for induction ovulation in the woman. In about 1970s, Donini make special technique to extract it, this hormone from the urine of the men in late postmenopausal period. So this is today's drug which we use and know as human menopausal gonadotropin. It is extracted from the urine of postmenopausal women. So Blumenfeld then the first time used it also for induction ovulation ahead of first pregnancy. Also so-called HCG hormone is used for rupture of the follicle, and it is extracted from the urine of the pregnant woman. So it is a little bit from the history that you know this. The hormones of the ovary are steroids, and shall we go there? They have so-called cyclopentanoepeptide or pentatene structure, which consists of three 6-ringing and 2 5-ringing structure, and because of C atoms, we know C18 steroids, which are estrogen, C19 steroids, which are androgens, and C21 steroids, which are gestogens. Also, they are different in their action. For example, 17 beta estradiol is the strongest estradiol, and this is, for example, 500 more stronger than estrone. All estrogens are secreting in the ovary in the theca cells. But in ovary is also producing progesterone in the second period of the cycle, and it is actually produced from the granulosa cells in corpus luteum. And you know, all steroids actually are beginning from 2 C atoms. Then with doing a lot of enzymes, we have cholesterol, and cholesterol then is going to pregnenolone, and in simple way we have progesterone. But it is a much complicated way from progesterone to estrogen. So androgens are precursors of the estrogen after process of aromatization and oxygenation. Also, if we speak about the biology effect of the estrogen and progesterone, it is on the whole body. So estrogen actually responsible for contraction of the uterus and the tube, for action of the cilia in the tubes. They also making cervical mucus more liquid, so everything is prepared for easily passing sperms and later fertilized ovum. Also, epithelial vagina is thin, and we can found them glycogen, which together with leather-like bacil make milk acid, which make pH of vagina acid, and so protected it from the infection. Also, endometrium under the estrogens become bigger because thicker, because arising some spiral arteries, and later about the period of ovulation also is retention of water. Progesterone, then estrogen also are important because through the thermoregulative center they make the basal body temperature low, and also they have anabolic effect to the bones, and they have also function for developing of secondary sex characteristic as mamas and secondary sex hair. Progesterone has completely different action, so no contraction of the uterus, no contraction of tubes. Endometrium becomes more thicker because not only arising the spiral arteries, but also forming glands. These glands at the beginning are full of secretion, and in these cells of glands there are typical founding of some vacuolas, glycogen vacuolas, which push the nucleus from periphery to the center of the cells, and also later on stop secretion in the glands, and we have predecidual reaction. So everything is preparing for predation of fertilized egg. This is the effect of progesterone. Also through the thermoregulation of the center, they make higher basal body temperature, they also have anabolic effect to the bones, and they also are responsible for developing secondary sex characteristics, mamas as, and secondary sex hair, the same as estrogens. Can we have next? So when we speak about these hormones which I was mentioned, it is, this one I think is not working. At first, you cannot see it on the right, yes you can see. You see, at the first when we speak about gonadotropins, I would like to say that the gonadotropins at the beginning of the cycle are high. They are producing a big amount, and because of a lot of follicles in ovary started to grow, these follicles started to produce estrogen, and because of that the FSH is going down, and just about the ovulation they have a little peak and then is decreasing, and it is on the lowest level during the bleeding. Estrogens are low at the beginning of the cycle, and as I mentioned that few follicles started to grow, producing estrogen, so the level is rising, and this peak is close to the ovulation, then it's going down, and we have another small peak 6-7 days after ovulation, and then again is decreasing, and it is at the lowest level at the menstrual bleeding. How about LH? He said that for completely maturity of the follicle, it is very necessary to have the both of gonadotropins, FSH and LH. LH is necessary and started to action to form the follicle from the antrum folliculi, when we have this stage of folliculi. So coming close to the ovulation, about 6 hours before the ovulation they have its peak, and it stays like that about 24 hours because it is necessary for completely maturity of the follicle and for ovulation. Then it's roughly decreasing, and again it is at the lowest level during the bleeding. Progesterone, as we mentioned, is the hormone of the corpus luteum, so it is on the very low level actually in the follicular phase of the menstrual cycle. But after formation of corpus luteum, it is 6-7 days after ovulation, they have their peak, and then is again going down during the bleeding. But 34 to 48 hours after ovulation, we can find it in the urine like pregnant diol. When we speak about the endometrium, we have to say that the endometrium of the woman is changing during all the life. So it is changing from neonatal period till the sapium. In neonatal period, endometrium will be in secretory phase because of passing hormones through placenta from the mother. But then in the childhood, the endometrium is very thin because there is no influence from the mother's hormone, no own hormones, and it is very thin. Endometrium maybe have only a few glands. When we approach to the menarche and hypothalamus center waking up, they send impulse to gonadotropins, which sends impulse signals to the ovary, and secretion of estrogen started. Close to menarche, we will have the endometrium in the early proliferative phase. And in samium, it is again a trophic thin organ with no spiral arteries, only with some glands. But in generative age, endometrium is actually consisting of 3 layers. It is basal layer and it is functional layer. This functional layer is forming from spongious and from compact layer. It means actually the layer which is full of glands and the tissue surrounding the glands, and because it is destroyed and go away with bleeding every month, we call it functional layer. And it is always regenerated from the basal layer, which is always constant. There are also two kinds of vessels in the endometrium. One are thin narrow vessels which are only in the basal layer and never pass through the border to spongious and compact part. And there are another one which are only in the functional layer. These are actually spiral arteries, which are branches from the radial arteries from myometrium. They communicate with one to another, so they're making big nets, what is necessary for nidation of the fertilized egg, and also they have connection with some venules there, finishing in venous lacunas, so everything preparing for nidation. During the menstrual cycle, we actually can, in generative age of woman, we have three phases. You know about all this, but we will shortly repeat it. First is follicular phase of the cycle, or proliferative phase, which started on the 5th day of the cycle and finished on the 13th day of the cycle. And it is characterized by the estrogen influence in the endometrium. It means that the endometrium become thicker, they are rising in the spiral arteries, and also close to the ovulation it will be retention of some water. Then from 14 to 26th day of the cycle, we have luteal phase or secretory phase. I said under the progesterone from granulosa cells of the corpus luteum, which is characterized to become much more thicker with these glands which we mentioned before, with secretion glands, and at the end stopping secretion glands and making this preludial reaction. If the pregnancy didn't happen, this endometrium is going to the third phase of the cycle, which we call the phase of destruction, because the spiral, the coming of the estrogen and progesterone stop, so the spiral arteries rupture because of ischemia. It is necrosis, desquamation, detritus, and everything is going away with bleeding. Interesting is when we have a process of bleeding, so this third phase of the cycle, at the same time gonadotropins rising, they new follicle in the ovary is starting to grow, so they are starting to produce estrogen, and they again influence the endometrium, that it's also at the same time starting to be rebuilt from the constant basal layer. So this is this cycle in the, we can go there. So you know everything is in connection. You know the growth of the ovarian follicle from primary, secondary, tertiary, to ovulation, to formation of corpus luteum. Everything is under the control of estrogen, progesterone, and also we have this following all this process, as I mentioned, in endometrium, which is growing and which is going away if the pregnancy didn't happen. When we do not have ultrasound, many years ago, we were oriented about the ovulation also by putting the patient on the table, looking at the speculum and looking for the cervical mucus. You know that before the ovulation, this mucus is very dry, so very poor, and then prior to the ovulation it becomes more wet, and it is peak day about the ovulation when the mucus is like cascades. You can see it, so-called pupil effect, and if you look at the microscope, you can see the phenomenon of crystallization, or if you remember it, and after then it is again infertile period. It is again to show the growing of the follicle, the ovulation, and that LH is very important for ovulation because it has its peak 6 hours before it, and say about that about next 24 hours. And that also progesterone, which is usually about 2.5 picogram on milliliter. After ovulation, she is always bigger than 10 nanogram per milliliter. So to repeat it, so that menstrual cycle have a follicular phase, which can be first of all variable duration. If the patient is measuring basal body temperature, it is low. If we follow up what happened in ovary, you can see the folliculogenesis, means the growth of the follicle, and If you look at the endometrium, it becomes more hypoechoic, and it will be this special halo, which we call ovulatory ring. Hackler actually in 1972 called it ovulatory ring, because he think that this special three-lining endometrium has only patient with ovulation. But later on it was shown that it is actually result of doing and progesterone on the endometrium, because the superficial layer of the endometrium is diluted from the basal and some retention of water can, and because of that we have this halo which can mimic early gestational sac in the endometrium, and who is not experienced, it can be maybe missed. I'm sorry. The next slide is when we have secretory phase of the cycle, it is constant, usually between 12 and 16 days. This is a rising basal body temperature and corpuscular formation under the progesterone is formed. So we talk about all this, that we will have maximum about 7 to 16 millimeter endometrium, that is glands because it becomes tortuous and filled with glycogen, vacuolas in the cells. We talk about all this, okay, as we prepare the foundation. Also we speak about this table about the level of the hormones. FSH high at the beginning, then falling down, then little peak of ovulation, and then decreasing. Estradiol, which is rising before ovulation, and so on. Okay, we will not take it again. So, how can ultrasound be useful in following up the menstrual cycle? First of all, we can present the follicles in the ovary. So we first time can see actually what happened in the ovary, and we can measure this follicular every day. We can also see the number of the follicles, and with new generation of ultrasound machine, we can also measure perifollicular blood flow, so to know something more, not only about the anatomy, but also something about the physiology. And at the same time, we always have to look at the uterus to see the endometrial thickness, echogenicity, and also to measure the subendometrial blood flow. Of course, at the beginning, we have only transabdominal sonography. When we started to work 30 years ago, actually, we have static machines. With these static machines, we were actually driving the picture by taking transducer from one to another side, and we have very big linear probes, which are good for obstetrician because the fetus was after the thin abdomen wall in the water, and you can easily find everything what you were interested to see. Of course, no movements because the starting of this. But at this time, we were also possible to present the uterus, but we must have very full urinary bladder, so it was not very comfortable for the patient because the bowels were going up, and then we have looked to the small pelvis. After that, you know, we have real-time machines comes, in which it was very big revolution for the obstetrics because you can see the movement of the baby, everything else, but also for gynecology because it was now produced the small probes which were possible to be moved and to easily see the organs and to have only presentation of one ovary and to see more precise what is there. But after that, you can go there. As you can see here, we can see actually with this full bladder very good presentation of the uterus, and we see the endometrium. You can see the echogenicity of the uterus and this triple-lined endometrium in the uterus. But with transvaginal ultrasound, we do not need full bladder, so it is much more comfortable for the patient, and we are much closer to the organ which we are observing, and our picture, ultrasonic presentation will be much more clear, much more precise. Okay. As you can see here, this is transvaginal sonography. You can see you are much more closer to the organ of our interest and to see much more details. So it is also a comparison, for example, this early gestational sac. You can see it very good, of course, with transabdominal sonography, with full urinary bladder, but you are much more closer to the organ, maybe more details, more easy by transvaginal. I must tell you, I first time see these slides because I have presentation in Croatian and it is a little bit different, but I make it for you young doctors in English and they change some. So over in transvaginal color Doppler, to see the ovary with follicles, how can we see the presentation of the follicle? You see, like hypoechogenic structure, you know, with very thin walls, which can be very good separated from the surrounding tissue. And when the woman is in reproductive age, in generative age, it is easiest to detect the ovary because of these follicles, because they have this unhypogenic cystic structure inside. In the woman in postmenopausal period, there is no follicles and the ovaries are small, so it is difficult to differentiate them from the surrounding tissue. So all this process actually in the ovary, growing of the follicle and the mature ovarian follicle, we can recognize today by ultrasound, also formation of corpus luteum and also very early mutation in the uterus. When we started to measure the follicle, usually about 8 to 10 days of the cycle, and then the diameter is about 10 millimeter. When we have started to do it, we started earlier even, but not measuring the structure less than 4 millimeter, because then we will be not sure that it's maybe some artifact. But now it's transvaginal color Doppler, we started at 8 to 10 days. And we can do it every second or every third day or every day if it is polycystic ovary. It depends from patient to patient. And it is very good that one woman is following the same examiner, because you know what was yesterday and you know what is today. It is not good that every day she is seen with somebody else. Then you will be not so precise and you will be not well informed. You will not have good result. So maximum diameter is between 18 and 23 millimeter, and we know that the daily growth of the ovarian follicle is about 2 to 3 millimeter. Everything is normal. So here on this graph you can see that the measuring a lot of cycles, we found that actually the diameter of the Graafian follicle is between 18 to 22 millimeter. So this is conclusion, but you will see later on why this is important. Also, the growing of ovarian follicle is parallel, is linear with the level of the estradiol. We also said that the peak of the follicle diameter, when it is at the highest level, it is also the highest level of the LH. It is all coordinated. So by transabdominal sonography, you can see one of these follicle and the cystic unhypogenic structure with thin walls. You can easily measure the diameter. You can measure if it is more ellipsoid in form, you can measure the shortest, the biggest diameter. You can measure the surface of the follicle. You can measure the volume for formula of ellipsa. But today, with this new generation of machines, you can directly know the volume from the machine. But usually in everyday practical work, we are measuring only the largest diameter of the follicle. And you can see that it is very easy to be detected from the surrounding ovarian tissue. Today, with three-dimensional ultrasound, This is the presentation of the ovary, and these are follicles, and you can even find some structure inside of the follicle, as it is here, cumulus operos. You know, the cumulus operos, actually, we observing a lot of cycles found that we can find them when we have mature graphene follicle. It means that it is measuring about 80 mm in diameter, and this is like one anapogenic structure on the inside wall of the follicle, and it can be presented in about 20% of the following patients. So it is just what I mentioned. I put this slide, which is maybe historical slide. You can see I said that when we started more than 25 years ago, we use static ultrasonic machines. It means they have only grayscale. They do not have real-time, no color Doppler, nothing. And we would draw in the picture, just passing transducer from one to another side of the abdomen. And you see, as far as it was in 1970s, it was possible to present the follicle in the ovary and even the formation of cumulus operos. If you compare this histological picture, you see even at that time it was possible to see, of course not so precise and not so easy as today. Okay? And today transvaginal color Doppler. And you can see these cumulus operos like Cochrane on one side of the follicle, and if you found it, you can predict the ovulation for next, let's say, 24 hours. How to present these cumulus operos by 3D technique is here, and after that we can also next day, and the patient found disappearance of follicle, and you can find the corpus luteum formation. And so the diameter of the follicle becomes decreasing, and you can find some echoes inside. It is actually bleeding and collapsed into the follicle. It is fresh corpus luteum formation, and also you can find some free liquid called the subindominal sponge. Okay? So it is typical presentation of corpus luteum formation with these echoes inside, and if you include color Doppler, you can take one cardiac cycle and measure the blood flow as well as in following two. Okay? So today, with this new generation of machines, we can measure the blood flow from all vessels, not only from uterine arteries, radial, myometrial, arcuate arteries from myometrium, but also subendometrial, so-called spiral arteries, then from the ovary, and from the follicle, and from the corpus luteum. So we can know a lot about physiology of some person. Okay? This is this whole system which is possible to be ultrasonically measured today with machines. Okay? So if we said how can we detect the ovulation by color Doppler, we have to know that the resistant index, which we measure in the follicle phase, so-called pre-ovulatory phase, it is about 0.54 plus minus 0.04. But just prior to the ovulation, it increased because of much vascularization of the higher velocity of the blood flow, and during the ovulation this resistance will decrease to about 0.44, and in luteal phase it stay like that next 4 to 5 days, and other day it is again rising, and it is about 0.50, but never such high as it was in follicular phase. So this perifollicular blood flow, which is here 0.50 in the follicular phase, significantly decrease in the ovulation. It was about 0.42 to 0.48. This is the same presented by a graph. You know, the high resistant index decreasing in ovulation, and again increasing, but not the same as in follicular phase. This is follicle, taking one cardiac cycle and measuring the blood flow. again the same. This is presentation of follicle by 3D machines, including the color Doppler. Okay. You see very good peri-ovulatory circulation, 2 follicles, very good presentation of blood flow. Why is this? Can we return next, yes? Why this perifollicular vascularization is important for us? So as I said, we don't measure only the diameter of follicle, not only the number of follicle, but this blood flow is, we believe that probably this follicle, which is very good supply with blood, maybe have all seeds, because you know that some follicle can be empty. So we can predict that it can be maybe filled with mature oocyte. So it is also possibility to be later on fertilization. And if endometrium is also pink and good with subendometrial also vascularity, maybe it will be possibility for implantation. So we can suppose that we will be successful in our patient, or if everything happens in spontaneous cycle, that it will be maybe good ovulatory cycle. If we are lucky and have also machines with power Doppler, we can present, you see, so good pre-ovulatory blood flow with circulation under the follicle, which means that the follicle is okay. Can I help you?
Slide before.
Can you see the first slide before? Yeah, this is important. Just to so good quality of oocyte maybe is when found the blood flow and possibility to go later position. Okay. Also, he was made a study by Dr. Kupčić. He published it in Fertility and Sterility, looking at many patients in the menstrual cycle, and she found that actually in corpus luteum period it is 3 stages. It is the stage of vascularization, stage of maturation, and stage of regression. So as you remember, in follicular phase, the resistant index was about 0.54. Then decreasing about ovulation. This about 0.42 to 46 is actually, in the first stage of vascularization, this resistant index was the same as it was in the period of ovulation, about 0.43. But when follicle started to be corpus luteum started to be organized to mature follicle, then again resistant index is rising. It is about 0.40, and when it is regressing, it is again rising to 0.50. But never the same as it was in follicular phase. It is again now presenting how we can measure it, taking into account the cycle and the vascularity. So next, again, next is presented in all 3 phases and regression. Okay. Again, it's presented with the graph, how we can measure, how we can count all these 3 phases. Again, by 3D and power Doppler. Okay, how it is ultrasound useful in some other situation, not only patient with ovulation, with patient with anovulation or maybe with polycystic ovaries. What we are looking at, what ultrasound can help. So if we have patient with ovulation, we mentioned that we can follow up the growing follicle, and we can recognize the mature grafting follicle because the diameter will be between 8 and 25 millimeter, and that this dominant during the ovulation will disappear. At the same time, endometrium will become thicker. It will be triple line endometrium, measuring about 7 to 12 millimeter in diameter, and in luteal phase it will become more hyperechogenic, very easy to be seen. Of course, that we will have such conclusion, we have to make several examinations during the cycle. But if we have patients with anovulation, we can follow the growth of ovarian follicle, and we will see that they will never reach more than 10 to 12 millimeters. So we will have the regular growth of the follicle. It will be never mature graphene follicle. Also, it will be a low response to the endometrium. It will be no triple line, it will be single line endometrium, and it will be no change in secretory interface of endometrium. How about some hormonal level? Because it is no ovulation, you will have low level of estrogens, you will not have LH peak, and also progesterone will be low, about 2.5 picogram per milliliter, because ovulation didn't happen. If we have patient with polycystic ovary, first of all we will have typical ultrasound image of the ovary, which will be enlarged about maybe 8 or more centimeter in diameter, and you can see a lot of immature follicles, which are like a pearl under the cortex of the ovary, and you have very rich stroma. And endometrium can be atypical, but there are typical findings by hormonal assay, because you can high level of LH in this patient, and you can have FSH LH inversion. It means that FSH can be normal but LH high, and if it is typical patient with Stein-Havital syndrome, you will have also high level of androgens, 17 corticosteroids, testosterone, and testosterone. If we have patients with so-called LUF syndrome was first time noticed by ultrasound. Before that, we have patients with high basal body temperature, with LH peak, and so on. But when we look at the ultrasound, we can see that there is not a good progression of growth of the follicle. So there is no ovulation, and if we do laparoscopy, we haven't found the stigma that the ovulation happened, that was the rupture of the follicle. Endometrium can be normal or change, and hormonal finding was normal. So we can find it only by the ultrasound, and we can treat it as the patient with ovulation. If you have EPD syndrome, you can see normal follicular development, weakened detection of ovulation, but you know, early secretory transformation of the endometrium can be, and decreased progesterone. One situation is, we call it silent ovaries, ovaries with no answer. So there will be no follicular development. We can have small ovaries, small follicles which are not growing, they are immature, they never reach diameter of the graphene follicle. Of course, endometrium will be one line, so very thick endometrium, and if we make hormonal analysis, we will have increased FSH and low level of estrogen. So it will be the same at menopausal patient. Also, we will have very thick endometrium, and we will have high level of FSH and low level of estrogen, but in comparison with the silent ovaries, we will have no follicles. Okay? Yeah? What is ultrasound is very important to predict in the stimulating cycles, the hyperstimulation. These are actually my patients, and I do not think that it was a success because it was quadruplets. And it was patient actually with polycystic ovary. She is Macedonian but living in Slovenia some years ago, and it was only stimulation with clomiphene monoclonal menopausal gonadotropins. And she returned that I gave her drug, and she visited me when she was 18 weeks pregnant, and we found, you know, quadruplets. After that she was hospitalized here, and everything happened okay. It was 3 nice girls and 1 boy, but all the same it can finish different. Even it was no cesarean section. They were all about 2,000. It was very, very successful, but not always. Okay, can you say see? So if we follow the patients with who are undergoing stimulating ovulation, we found that the growth rate of the ovarian follicle is very similar as in the spontaneous cycle, but a little bit shorter period is necessary, and the diameter of the follicle is a little bit bigger than the normal cycling hormone. I put this table here because it is from 1982. You see, because I think it is important. If we at that time look at the literature, the people who are measuring the follicles undergoing stimulation of hormone-sensitive drug or human menopausal gonadotropins, what we can see was actually, you see that we didn't know what is actually the diameter of pre-ovulatory of Graafian follicle. You know, Yistalo from Finland, he found that it is 15.4 millimeter. Renault from France said it is 24. And you know, Picker said it is 13 millimeter. And you know, it was so big differences that we actually do not know what is the mature diameter of the mature follicle. Is it 15 or it is 13 millimeter in diameter? And when we look at spontaneous cycle, it was the same. You know, Hall found that the diameter is 10 millimeter, and you know, Renault from France found it is 27 millimeter. So at that time, it was at the beginning of 80s, the study group sit down in Dubrovnik conference, and they were discussing, and the conclusion was, because all these women were from the Europe, and they use actually the same technology, very similar machines, that it must be a mistake during the measurement. So they conclude that they have to measure the follicle from inside to inside. Because somebody to measure it from outside to outside, somebody from inside to inside of the follicle wall, and somebody from outside to inside, like for BPD of the fetal head. And also that you always must found the vessels coming to the ovary, that they are guiding you that you are measuring the follicle always at the same level. And after that, it was conclusion that the mature ovarian follicle has diameter between 18 and 22 millimeter. So this is a presentation of Louvre syndrome. You see two unruptured follicles. If you follow them, they will not grow anymore. If you make laparoscopy, no stigma, and so in this patient you have to have stimulation ovulation therapy. This is from my doctor thesis, a very old slide from 82, when we first time started to measure our patient. We have a group of spontaneous cycling women and a group who were going under clomiphene and gonadotropin cycle. Also, it was a very small group with clomipene, patient with galactorrhea and amenorrhea, but it was too small group, we do not put it here. And what we found that it was significant difference between growing follicle and spontaneous cycle comparing with this hormonal treatment patient, but it was not significant difference between the diameter between these two stimulating groups. Also, we found that the everyday growth of the follicle is about 2 to 3 millimeter. It was 20 years ago. And also, we found that the growth of ovarian follicle is linear with the thickness of the endometrium, which we today know. What are the complications when we have stimulate cycle? I say the complication which we are always afraid, not only that we will give a small drug and we will be unsuccessful because we will have low growing follicle, but more complicated if we do much more, if we give much more drug and we have hyperstimulation syndrome. So if we are not careful with ultrasonic examination and not see the patient every second day, you can have this hyperstimulation syndrome, which is in literature described about in 24%. And consequence of this will be multiple pregnancy, which happened in 22% of twins, in 4.3% of triplets, and in 0.4% of quadruplets. Also, complication is spontaneous abortion, which is more than 20% in vitro fertilization patient in comparison in 10% in spontaneous pregnancies. What is risk factor for hyperstimulation? Of course, polycystic ovary. We are always afraid to have HPV polycystic ovary. Why? Because if you we usually have started to give clomiphene, let's say, first, if it is normal gonadotrophic patient, but very careful. We have to see it third day of the therapy. And at this patient, usually all the follicles started to grow. If we give in ampoules, Humegon or Perigonal or so on, we use only in polycystic ovary, only therapy which is used, it is pure FSH. So it means Metrogyl or Gonal F. We never use Perigonal or Humegon because, you know, this drug have FSH and LH hormone. Because this patient has a lot of LH, you have to give him only drug with FSH, and this is Metrogyl or Gonal F. And very carefully starting only with 2 ampoules and look at the third day of the therapy. Metrogyl, yes, Metrogyl or Gonal F. This is one, you know, typical ovary. And you see all these small follicles, when you give the drug, all started to grow immediately. And you know, we like to have 2 or 3 follicles in every ovary, but not 12. And we also, during our vitro program patients, which we have in polycystic ovary, you have to give the drug more and more. Because if the diameter is 12 or 13, it is not mature follicle, so you do nothing. So we try to puncture one ovary and to continue with drug to have only follicle from one side. We try to do many things, but it is also very difficult to balance and to do not have hyperstimulation. The next one, you see another one with lot of follicles with very good vascularity. So if we have low or middle hyperstimulation, this is something what we wanted to have, because we must have few follicles, then our rate of success will be better. Especially in the same analysis, it is not good, so to have possibility to fertilize some more like eggs and to choose the good one for embryo transfer. But if you have the ovary, which is 8 to 10 millimeter in diameter, with so many cystic structure inside, multiple follicles, and if the control of estrogen is more than 2000, and you can have some free lipids in the abdomen, later on if you give HCG ampoule, after that you can have very high hyperstimulation with ascites, with also pleural effusion, and it can finish with cardiovascular or renal insufficiency and can finish better. So in the period when we do not have ultrasound, I must say we do not give this therapy by outpatient clinic. All the patients were hospitalized or had bed resting, and every day they were on the table, we were palpating, and the patients were collecting 24 hours urine. You know, it was not rather to say to have blood test, they would have to collect the urine, and we have the results 2 days later. So we don't know what happened today. What happened today, we know 2 days after. So it was very difficult, and when the patient is repeated this therapy, then we were guiding by the previous cycle what happened actually. So it was not easy to follow it. Today you can see immediately by ultrasound what happened, and if it is going wrong with hyperstimulation, we can just stop therapy. Or it is very important not to give HCG. Then nothing will be happening. And no doing insemination, no doing in vitro fertilization, just to stop. Okay? This is one presentation of one hyperstimulated ovary. Another one, with blood flow, how this looks like by 3D. Okay, this is about uterine vascularity, we speak about all these branches. You have to see it. You know, its arcuate artery, and all this present, and see this uterus also is prepared for the fertilized egg. Everything is controlled by central nervous system, hypothalamus, and okay, we talk about what we are measuring as the endometrium. We measure the midline endometrium in the sagittal plane in the uterus, which is usually in the long axis. This is the position of uterus when we have to measure this triple line endometrium, and it also depends on the phase of the menstrual cycle, which is 10-year cycle. So this is presentation how we measure this endometrium. All three lines. This is triple line endometrium with one cardiac cycle to measure the blood flow. We speak about it. This is this ovulatory ring, which Hackler first time mentioned during the ovulation, which can be mimicked for early gestational sac at that time. They think not today, they will know about it. Next, please. Again, the secondary phase, also the blood flow to be measured from this. Again. Of course, if we have blood flow good in the endometrium, we must have a good blood flow also in the uterine artery, because it is a big. The next one, big vessel. Again. But here you can see that it is absent diastolic flow. It means that it is not good vascularity through this uterus. Next. When we go from the uterine to the radial artery, we can see that the resistance index is going down from uterine to radial to spiral arteries. Next. This is spiral arteries, nice presenting here. So if we found the good blood flow in spiral arteries, it means that is good endometrial perfusion, that is good uterine receptivity, and that will be success in implantation rate. Again, one presentation of this spiral artery blood flow. Again, examples. And here you can see again absent diastolic flow. So here we will be not success in such endometrium making the transfer. And this is again how outflow might obeys embryological life and also this gonadal dysgenesis. It means some mistake during the embryonic life on the gonads and on the uterus. And if we actually speak about this, we have to say a few words about the embryology and about the anatomy. Actually, the basis for embryonic ovary is one epitel of SILAM and mesenchyme, which stay in sagittal position, and it is like one plica which is called genital plica. In this epitel of SILAM and mesenchyme are presexual cells which can be later on developed in sperms or in ovum. And this is so-called indifferent stage of the gonad. But later on, this sagittal genital plica is diluted from the basal layer, and they stay with them only with one narrow connection with one membrane, in which later on will be developed mesovilum or mesoovum. And the cells will be then differentiated into the sperm or into the ovum. So it is this indifferent stage of the ovary. But when this when it is going into when these cells of organoids are there, and few layers of follicular cells are surrounding it, then we have the formation of primary follicle. At the same time, in 6 weeks of embryonic life, we have two channel system developed. One is, as you remember, Volkov system, and another is Miller system. so-called mesonephros and paramesonephros. And they have actually doubt possibility to develop, so it can be developed in the female or in male sex. In which way the development will go, it depends about the Y chromosome. So if it is presence of Y chromosome, then the gonad will be testis, and this system will develop as both of the system, and will have vas deferens, ductus epididymis, and so on. In the Miller ductus system will be atrophic. But if the Y chromosome is not there, then the Wolf system will be stay rudimentary. It will later on form the so-called epiform and ZAGREB channel, and the Miller system will be developed, and we will have, because of that, the gonad ovary, and from the Miller system we will develop later on the tubes, the uterus, and the two-thirds of upper part of the vagina. But if this fusion of Miller tubes are not made properly, you can have some later on anomalies in the genital tract. Okay, we can go next. But also we have to say some words about the anatomy of the low pelvis. You know actually that the pelvis is one bony link, which consists of symphysis in front, of the sacrum on the back, and the two parallel hip bones on the lateral sides. And if you imagine one oblique line will passing on the upper point of symphysis, going laterally and finish at the promontorium on the back, then this imagined line will divide the pelvis into the great pelvis which is up and low pelvis which is down. And our interest is actually this low pelvis because they are situated in genital organs which are our interest. But except genital organs, in low pelvis we can find some other organs. It is important to mention that because they can be weak for some other structures. So one of these organs are muscles, which can be sometimes seen by ultrasound presentation, and there is so-called musculus iliopsoas, who is actually in the great pelvis and consists of musculus psoas major and musculus iliacus. And it is like, you will see how it is presented by ultrasound later on. But there is also musculus levator ani, which occupied the inner part of the lateral part of the pelvic walls and have very bright fascia. So it is possible sometimes to be presented by ultrasound too. And going down, it is musculus levator ani, piriformis, and so therefore pelvis diaphragm. So the next, please. It is important that sometimes these muscles can be seen by ultrasound. If you have transabdominal presentation, and if you put the ultrasonic probe from upper point to the feet of the patient, like that, then after very full urinary bladder, you can see, first of all, laterally and on the lateral wall of the urinary bladder, you can see the musculus iliopsoas formation, and as hypoechoic triangular formation as it is here. More deeply will be musculus operatorius internus, more deeply levator ani, and so on. Of course, we will never look for the muscles on our ultrasonic presentation, but sometimes if you have examination, abdominal examination of girl, little girl, or the woman which have very thick abdomen, which are not fat, this formation of iliopsoas muscle can be presented. So you can mimic it for the ovary and so on. This is why we speak about it. You see here another presentation after full bladder. You have the central organ of the low pelvis, uterus, and lateral and superior to the uterus you can see the ovaries, which are a little bit more hypoechogenic than the uterus. And the Kratofil in 72, who was the first one who used ultrasound presentation of non-pregnant woman, so gynecological patient. He described that the uterus together with ovaries making so-called semicircular axis, in which the ovaries are making to 1/3 of the size of the uterus. And you see more laterally and more superior to the ovary, it is this hypoechogenic triangular structure of musculus sclerosus, and on this muscle are laying the vessels. So sometimes it is possible to present Iliopsoas muscle. The next, please. But more important for us are actually the vessels, especially with new generation of ultrasonic machines, because not only anatomical presentation of the vessels, as you know, as you see, that we today can measure the blood flow. Also, a note about the function of organ of our interest. All the vessels which we found in the lower pelvis are actually coming from the abdominal aorta, from then arteria iliaca communis, who are at the level of fifth vertebral body, is dividing into arteria communis externa and interna, arteria iliaca externa and interna, and all these vessels are following about the same veins, same name veins, but they are positioned more posterior and more medial than the arteries. Arteria iliaca externa is passing then through inguinal channel and finishing as femoral artery, and arteria iliaca interna is coming down, passing after the ovary and after the vessels and going to the small pelvis. You know, when we have these real-time machines, it was new revolution period because we were more precise to present one and another ovaries and to presenting some veins. And if we now speak about the uterus as a central organ of the low pelvis, we have to describe first of all the fundus of the uterus, which is always is important to say convex, which is convex if this is normal hormonally stimulated uterus in general age. So convex position of the fundus. Then we describe the body of the uterus, which consists of corpus and cervix, and between corpus and cervix is isthmus, which is very important during the pregnancy, like low uterine segment. Then it is vaginal part of the cervix. Then we describe intrauterine cavity. It is actually a cervical channel which continue in the intrauterine cavity, and we can present by ultrasound the endometrium, the myometrium, and also this out part, endometrium, out part of the uterus. This is coronal or frontal presentation of the uterus. If we have longitudinal view of the uterus, we can present the so-called anterior and posterior uterus. It means actually vesico-uterine and recto-uterine space. We can also present the anterior and posterior part of the vagina. We can present the urine bladder and the so-called rectal space, which is the space between the bladder and the uterus. Next, please. As I mentioned, the uterus is an organ situated in the midline of the pelvis, and it can be a little bit pushed to the left or to the right. It depends on the ligaments, of the ovarian position, and so on. All of this is normal, but usually it is in the middle line, and it is a little bit anteverted. It means turned to the front. But uterus can be also additionally anteflected. So in this case, it makes a pretty sharp angle between cervix and the corpus. It is at the majority of the women. But some other women can have uterus which is retroverted. It means pushed to the back, and it can be additionally retroflected. It means again it is more stronger, more sharp angle between cervix and the corpus. So it is all position which you can detect by ultrasound. This is again our abdominal presentation, the central organ uterus after the full bladder, and you can see the ovary and superior to the ovary, it is this iliopsoas muscle, and you can see the external ilium vein and external ilium artery. I said the vein is more medial and more posterior to the artery. So it was even possible to present them with real-time abdominal machines. On the oblique or longitudinal scan, after the full urinary bladder, you can see formation of the ovary, like ovoid hypoepigenic structure, but posterior to the ovary is the vessels. This time it is internal iliac artery and internal iliac vein. They are presenting as a tubular structure with bright walls, with hypoepigenic center, which is urine, with bladder which is passing, and we can see in artery fetal heartbeat. But in between these vessels and the ovary, it is ureter, which is possible to be presented, and you see the very brightened walls of the ureter, more hyperechoganic than the walls of the vessels, and you can see also hypoepigenic center. This is passing urine, and you can notice the peristaltic of the urine. Also the orificium of ureter in the urinary bladder, on the posterior triangle of the bladder, you can see sometimes coming new urine, like sparking phenomenon, jet phenomenon, so called, because of changing of osmotic pressure in the blood. It is important if you have patient with one kidney, so to prevent the malformation, or if you have some anomalies in development of uterus, then you have also to think about maybe some anomalies in urine tract too. This is oblique scan. After the full bladder, you can also sometimes present external iliac artery, but not also the external iliac vein if the bladder is too full. The next. This is a very old slide. We can just pass through presentation of ureter also because of fascia that we can see from transabdominal scan too. Also very, very old slide. You can see the whole uterine body, the corpus, the cervix, and also the vagina, which is tubular structure situated between the bladder on the front and the central column on the back. And in the vagina you can have hyperechoganic center, which is actually the mucus when the both sides are going together. So let us speak about the uterus as a central organ of the small pelvis. When we describe the uterus, we have to speak about the position, about the size, about the contour, about the shape, about the texture, and about the central echo in the middle. So, about the position, we said it is in the middle of the small pelvis, about the length, about the diameter, we can say that we are measuring uterus actually from the upper point of the fundus to the upper point of the cervix. It is longitudinal. Then we can measure sagittal dimension, and if you put transducer in transversal scan, we can measure anteroposterior dimension. If we suppose that the uterus is like ellipse, we can measure the volume of the uterus, the formula of ellipse, or we can measure the surface and so on. But again, usually in our everyday work, we actually measure just the longitudinal and transversal diameter of the uterus. Then I said we have to speak about the shape. The shape is about the pipe or about the pier. The contour is very easy to be followed because he is differentiated from the surrounding tissue. So if you can follow the contour of the uterus, and the texture of the uterus when we describe it is homogeneous. Homogenic structure of the uterus means that it is consists of low and middle high echoes. And in this we can very easily recognize the central echo, which is endometrium, and which is changing during the menstrual cycle. So in the first stage of cycle it will be very thin, and it is much more precise to be seen in the secretory phase. So you see here is much precise and much easier to detect the endometrium. So if you are looking for some anomalies of the uterus, it is better to look the patient in secretory phase because endometrium can be, sorry?
Can I ask you?
Yes.
When we describe the homogeneity of the uterus,
yes,
and we say it is homogeneous,
yes,
do we exclude the endometrium from this? Because endometrium
yes,
changes its ecogenicity.
Yes, we are describing first ecogenicity of the endometrium, and then we describe the endometrium after that.
Then we are talking about the myometrium only.
Yeah.
In this case, at least.
Yeah, I speak now about normal anatomy. When we, for example, you have patient who is coming and you have now to describe it. You will describe in this presentation of uterus in anteversion or anteretroversion with homogeneous echogenicity with the bright endometrium inside, and you will now describe the endometrium. The next, please. This is just presentation of the vessels. When we have this transabdominal scan, first of all, we have to describe the follicles in the ovary. This is ovary, and you can see internal iliac vessel, which is important to guiding us to the elevation of the follicles in the ovary. Other organs which can be seen during our examination is the bowels. You see they are behind, posterior to the uterus, like hypoechogenic, these round ellipse with structures, but you can see very easy now with this generation of ultrasonic machines because there is peristaltic and they are all the time moving, so it's very simple to present them. As we said, the size, the position, the shape of the uterus actually depends on the endocrinological status of the patient. So it is changing during the life. So in neonate, it means only 6 weeks old baby, the uterus will be very small organ, but still with small finger, actually we can palpate it because of influence of mother hormone passes the placenta. And even this uterus can be half to 1 centimeter high, longer, bigger than uterus of infant. And infant is from 6 weeks to the end of 2 years of life. So in this period it will be the smallest organ. After that, in childhood, it is from 2 years till menarche, it will slowly grow. It will be still no flexion between corpus and the cervix, and we will have infantile type of the uterus. It means that the cervix will be very long in comparison with the cervix. It will be 2/3 of the size of the uterus, and it will measure about 3.5 centimeters. But at puberty, it means about 8 to 12 years, when the hypothalamus waking up, send impulse to gonadotropins and then to the ovary, secretion of hormones, estrogen, progesterone started, and we will have rather quick development of the uterus, and now the corpus will grow much more quicker than the cervix. And after menarche, we will have normal length of the uterus, about 6 centimeters long and about 3 centimeters wide. It was my study many years ago when we were observing 50 girls, pre-menarchal and post-menarchal, and we were measuring the volume of the uterus because of small organ for formula of the IPSA. And you see, we started at 7 years old girls, and the volume was 0.4 cubic centimeter. After 10 years after hormonal influence, it was very quick growing of the uterus, and it was about 40 cubic centimeter at period or after puberty. Okay? And if we speak about adult uterus, always if you have transabdominal scan, you have to start it with transversal scan to present the homogeneous presentation of the uterus with central endometrium there, and with 2 hypoechogenic ovaries on the both sides. After that, we turn to the longitudinal scan of the uterus, and then it is in this axial scan, we measure anteroposterior diameter of endometrium, and we have to measure all three lines of the endometrium. Cervix is the down part of the uterus, which can be better presented on the sagittal scan, just behind the posterior angle of the urinary bladder, and it is continued to the vagina, which I said before, situated between the bladder and the sigmoid rectum. When we now speak about malformations of genital organs, some of them can be seen without ultrasound, some also help us ultrasound. It can be on the level of vagina, obstruction of vagina, Gardner-Dick cyst, or also some small tumors. The next, please. You know, one very simple malformation, but unfortunately not over-recognized, is imperforated hymen, which can be all variable possibility, like cubriforms, like all other. If it is not recognized, next please, then you know the blood is collected through following cycles, and the whole vagina will be full with the blood, so we will have hematocolpos, and if we even do not recognize what happened, then the uterus will fill with the blood, it is hematometra, and if this be the birth, if also the tubes are full with the blood, then it will be no pregnancy no more. You have to put out these sarcosalpins, you know, these tubes, and infertility will be there. So it is very important to recognize these. Of course, ultrasound is not necessarily the beginning. If you look at speculum, you can see such type of vagina.